start hard. You will expect an increase in arthritis and all that. You may have to give steroids, but we do it with an infectious disease person.
Thank you. So, any other thoughts? So, the take-home message is patient's immune status can alter the clinical presentation and the treatment course. So, in cases of atypical presentation and poor response to the appropriate treatment, it's better to consider the evaluation of immune status.
The only thing I'd like to add there is also normally associate single lesion, posterior core treatment rate. So toxo can also present like this in a very full blown sort of multiple lesions, and that happens suspect compression. That has to be in an immunocompromised state. So get the HIV, generally.
Thank you. So,
normally they also keep these patients very long on background. Also for the neurocystis cavity infection, so they will keep these patients on once a week or something of Bactrim for a very long time. I think twice a week. Basically, it hits both neurocystis as well as toxo, so they don't get back the activation.
Thank you. So we'll move on to our next case. Here is a 45-year-old lady who presented with some sudden painless depression of vision in both the eyes since 10 days. She was previously investigated and treated for bilateral papular edema with oral acetazolamide tablet 250 mg BD before presenting to us. Her MRI reports were normal and there was no improvement in her visual symptoms. When she presented to us, she gave a history of tinnitus for since 3 days. Her best corrected visual acuity in both eyes was 6 parts, and anterior segment there was no evidence of inflammation. And this is a fundus picture. Right eye in both the eyes there was a significant disc edema with pattern lines and few pockets of subretinal fluid and few white yellow lesions in the posterior. So this is the OCT picture of the right eye showing the thickened choroid with RPE undulations and subretinal fluid, which is seen more prominent in the left eye. So we diagnosed as it to be VKH disease and investigated her further. Except for ESR, rest of the investigations were within normal limits. And again, we referred her back to the neurologist to stop oral acetazolamide and started her on oral prednisolone 1 mg per kg body weight with gradual tapering dose. At 1 week follow-up, her best corrective visual acuity in both eyes were 6 parts and OCD, the comparative image showed the decrease in subretinal fluid and decrease in the choroidal thickness, decrease in the RP undulations. The similar picture at 1 week of follow-up in the left eye, you can see there is a decrease in the choroidal thickness, RP undulation, and significant reduction in subretinal fluid. So at 1 month of follow-up, she was on 30 mg oral prednisolone and her best corrected visual acuity was 6 parts and this fundus image, comparative image, at baseline there was a disc edema which significantly resolved at 1 month of follow-up in the right eye and similarly in the left eye also. And this is a comparative OCT picture showing complete resolution of the subretinal fluid with resolution of the RP undulation and decrease in the choroidal thickness. And is the comparative picture of left eye OCT showing complete resolution of subretinal fluid with decreased choroidal thickness and RP undulation. So I would like our panel members to opine. Would you consider fluorescein angiography to establish the diagnosis of VKH disease?
For me, fluorescent angiograph would be for me, ICG would be a better take here. I mean, if you have see here, there is a bilateral disc edema with fluid, with a thickened choroid, but there are no vitreous cells. So that's it. So here just a disc edema, probably the BIH will be there or nothing. But with the thing of increased choroid thickness, for me, two things will be VKH, three things actually. VKH posterior scleritis can be bilateral, and third one will be its sarcoma. So when I probably do my investigations, I would probably rule out these three as a main thing. And for me, for a VKH, I would prefer an ICG, and I would be looking at choroidal granulomas. Now, if I see choroidal granulomas, again, I know the course of steroids I'm going to give will not be enough. I will have to start them on immunomodulation right away. The focus of ours have changed. We don't want to see sunset glow fundus anymore. So ideally, the faster you treat and more aggressive you are, things settle down very well and they have a good prognosis. We've also had, I mean, if you look at the history of BKH, generally there is a tendency it can resolve by itself and you don't need long term. But those who recur are very bad. Like, you land up with a sunset glow, and this is what we don't want it to happen. So, if there is other factors, like there is a tinnitus also, there is things, so I would probably start immunomodulation right away. But if it, sometimes you can just have island folds and you may not see this amount of dyschedema. So those I will just probably look at it over some time. But the key will be to taper the steroids very slow. So in fact, I've even up to 4 to 5 months, they're on very, very low doses of steroid. And you can make out the minute you reduce it to a certain extent, is it coming back? And you use your OCT there to look at the choroidal thickness. So you do a EDI OCT to just see continuously monitoring. And if you feel it is increasing, then you know the disease is coming back. So then probably you step up your immunomodulation. So this is how probably I would.
Thank you. Any other thoughts on glaucoma?
Any headache, history of headache also?
She did complain of headache only, tinnitus history she gave.
Because due to the recurrence, I've seen the patient getting headache first and then they are followed by a recurrence. So headache is like a warning sign for us to again look into in depth the choroidal thickness and then step up the steroids or the
In patients and BKH, you look at the headache for before even the onset of things. So they characteristically come like as if something is good, I mean, like their eyes are getting squashed or something. That kind of stuffy, feeling they have. Very characteristic, as what Madam said. BKH classical. The minute you taper the steroid, you just ask them, "Are you getting back the headaches?" If they are getting back even the slightest, you do a EDI, there will be a thickness.
So, anything to add?
And just to stress upon the fact that a detailed evaluation and thorough evaluation of the face, because initially it was treated by the neurologist who appreciated only the disclaimer, but on closer examination it was something. So the need for a detailed fundus examination.
just yesterday another disclaimer and a bilateral disclaimer. So and associated with headache. So the neurologist had sent to opine whether it's like papilloma. And I was so confused because headache is there, which is chronic, and the disclaimer is there. But it is not looking at exactly papilloma for me. So what I did was just B scan, which showed it was an optic distribution. So some simple tests actually will give us a big clue. He was due for spinal tap for assessing other problems, but we can actually save other investigations, unnecessary interventions, just by doing simple tests like B scan. So any disclaimer, take a good history and your clinical findings will definitely guide you to do what to do next.
Just one last point I'd like to add for the benefit of everybody here. So BKH is really, really common. A lot of you may see it in your clinics. So most of the times you can pick it up on the OCT itself. So if you do an OCT and if you have access to an OCT, please do the OCT because you will find a diagnosis there itself. So most of the time you have this very RPE, so that's very classical of BKH. You have large amount of subretinal fluid. You may have little also depending on when they're present. And in the subretinal fluid you have some septations. You may find septa, you may find a lot of inflammatory cells. So and then if you ask them, they'll say they have tinnitus. You have to actually probe and answer. Headache is something they'll tell you on their own, but tinnitus is something if you ask them, they may tell you, yeah, it didn't happen. But not necessarily. But if you do that OCT, you will really see that undulating, that wavy RP, that subretinal fluid with the septa in it. Not necessarily, but most of the times it can be there. And yeah, if you see this edema, dilate and see because At least I've seen multiple cases because neurologists generally do not dilate, so they see the papilla edema and diagnose such papilla edema. But as ophthalmologists, we have a liberty, we can dilate and see. So you can pick up BKH actually. We had a yellowish fundus, you had, sometimes it may be just as very subtle ILM folds in the macula. Sometimes it's a proper exudative RD. So just dilate and see, do an OCT, you get a lot of information, and it's quite common actually. You can see a lot of BKH cases.
Thank you, sir.
We still give it, the vision is very low. Yeah, that we can just give oral medications. But we do, the steroid tapering is very slow.
There is one for IV cortisone in acute cases like that.
Yeah, we do. When the vision just drops, they do well.
I mean, most of the cases would you prefer to go with immunomodulated therapy in the first episode only in the VKH?
If it is classical, yes, in the sense, classical in the sense, if you have vitreous cells and you know this is going to progress. Now we are seeing post the vaccination, we used to see a lot of cases like this, choroidal thickening and something like a VKH-like presentation. So we really didn't know whether that was a trigger. So those cases we just gave very slow taper of steroids. Fortunately, they have not recurred back. But I think I individualize it like case by case thing. But if you see vitreous cells with papillitis with lot of SRFs, then those are those indicators for me to start with immunomodulation. The atypical ones like the ILM folds, they come as an initial presentation and you still don't see the vitreous cells. Those probably I would wait and see how things are, and if it is recurring, then probably I would start.
Thank you. Big case of disclaimer. Thank you.
Once again, thank you, ma'am. Thank you, panelists, for this enlightening discussion. May I now invite Dr. Roshni Gupta back on stage so we may benefit from her expertise on insight on some of her interesting, fascinating cases. That was a bit of a dilemma because most difficult cases, over the last 20 years, there are so many that were so difficult. But what I've tried to do is to pick out cases which have a lot of learning points. So the first case is case 1A and 1B. Okay. So we have, you'll see the trend that the ones I present are over several months or even years. This is first time I saw this gentleman in March 2022. Hyperthyroid patient with proptosis, late congestion, chemosis, pain. So when we look at the clinical activity score, and this is a very heartening tremor. Nowadays, both ophthalmologists and endocrinologists are actually looking at what are the indications of active inflammation. So this gentleman has CAS 4 out of 7, which is an indication for intravenous methylprednisolone. However, his calibration, vision, visual fields are normal, which means he does not have any dysthyroid neuropathy. And so he underwent intravenous methylprednisolone. The current UGOGO guidelines are weekly doses and usually at a single sitting, never more than 750 mg, other than in compressive optic neuropathy. So 500 for 6 weeks and then 250 for 6 weeks. So we look at a cumulative dose of 7.5 grams, not more than that, because beyond that you need to repeat the liver function test, etc., and then start on a second cycle test. And also, the current guidelines are to start mycophenolate mofetil usually by the third or fourth week of IPLP and continue for 6 months, 24 weeks of therapy. So, because it has been seen that if you give only this, about 35 to 40% will have flared up after you stop the steroids. So, mycophenolate helps to dampen the inflammation for a longer time. So he settled down nicely from March to June. And then in June 2022, he received a booster dose of COVID vaccine. Now, this is something interesting that has come up, that post-COVID vaccination, thyroid eye disease got worse. We've seen this in multiple patients. There have been several reports in the literature. This dose is because the patient had moderate to severe thyroid eye disease. Okay. Then in August 2022, he comes back. You can see the edema and erythema around the eyes is there, but the proptosis is not terrible. The retraction is not terrible, but the color vision is defective both eyes, and vision has dropped both eyes. So now he has transitioned onto the stage that we call sight-threatening thyroid eye disease, which comprises corneal breakdown and which comprises dysthyroid optic neuropathy. So the thing to take home from this is that just by looking at a patient, because there's not so much of proptosis, let us not assume that the patient is safe. So any thyroid eye disease patient, particularly in the first 1 year, 1.5 years, if the patient is coming for whatever reason, even if they say the eye is itching, they have chalazion, whatever, any visit, I would check vision, color vision, pupils, disc. These are the 4 things I would check without any exception. So when we look at the scans of this patient, it is very typical. If you look at, this is called the balance index. If you ask the radiologist, they will actually calculate and give it to you. But either vertically or horizontally, the mid orbit, that is after the globe is seen, posterior to the globe, if you measure the width of the recti versus the total width of the orbit, if it is less than 50%, it is almost never a compressive optic neuropathy. And if it is more than 60%, it is almost always a compressive optic neuropathy. So that is how the balance index comes in. And also, if you notice, yes, the recti are thickened and the tendons are fairly spared. But if you also look, the way it's literally glowing with the contrast. That means there's a lot of inflammatory action going on. It's taking up contrast that actively. And you will also see that the outline is kind of fuzzy. That also means there's a lot of inflammation going on. We usually, even when a patient has loss of color vision, loss of vision, and pupillary abnormality, it may be some other cause. So, as a corroborative measure, I would ask for a scan and imaging to make sure that yes, the muscles are actually compressing the optic nerve. Because who knows, that the patient just might be having one of the optic neuritis. So this is the one case where you do give the previous schedule of IPLP. Earlier, instead of 750 mg twice a week, this is the only case we give 1 gram 3 consecutive days. But this always has to be under monitoring, and we also check the liver function test. However, this patient did not show any improvement for 2 weeks. And then we go on to the indication for surgical decompression of orbit. Okay. So the plan is medial wall, lateral wall, and fat decompression. when we are doing a surgical decompression, the floor of the orbit doesn't really have a role. If you follow, the floor of the orbit is still here. Hmm? So if I decompress the floor, this is where I would take out the bone. But look at where the compression is. Here the muscles are not pressing the optic nerve. The muscles are pressing the optic nerve out here. And so, if you look, this is where you'll get the bang for the buck, the posterior orbit. Medial wall is, once again, a very critical area. We need to make sure that the entire medial wall, including posterior ethmoids, is cleared. I would transcaruncular approach. You may take the help of an ENT surgeon to make sure that the entire ethmoid is cleared and entire wall is taken out. So this is the most critical one. But it is also critical in that if you venture too roughly into the orbit, that is where you are going to hit the optic nerve. The end of the medial wall is the optic canal, A. And B, if once again you are aggressive and you get a CSF leak, this is where the CSF leak will continue. On the lateral wall, you see the thickness of the bone, we thin it out. It can give some amount of decompression, but in a particularly tight orbit, A, it helps us to approach the medial wall more easily. You get a little more, wiggle room to approach the medial wall. And secondly, it is known that 10 to 15% of patients with this kind of thick muscles after decompression will have squint, persistent double vision. Balanced decompression with both medial wall and lateral wall will give rise to less chance of double vision. So we went on to plan medial wall, lateral wall, and take out whatever fat we can. Fat removal will improve the proptosis. It will give us more space to tackle the bony walls. But the fat is also the target in the orbital inflammation. That is the end organ. The orbital fibroblasts. They have all the receptors. That is where the antibodies are working. Both the TSH receptor antibody and antibodies against IGF-1. So when you take out the fat, you're decreasing the chance of inflammation. So post decompression, color vision came back to normal. Vision is 6/6 and 6, but now the patient has esophagia. Lid edema, congestion, and chemosis are continuing. Okay, so this is definitely not surgically induced because after 6 weeks of surgery, I wouldn't expect the surgical inflammation going on. So he has active inflammation still going on. You can see the esophagia, you can see the edema, you can see the reddish erythema of the skin. You can see the congestion also. And the caruncle is congested. So what are the factors affecting teeth? What makes a patient have worse teeth? So instead of looking only at the eye and the systemic thyroid condition, these diabetes gives patient worse thyroid eye disease, more likely to have severe and sight-threatening eye disease, and more refractory to treatment. So diabetes has to be treated. Western literature doesn't really talk about diabetes, but coincidentally in 2020, 3 large Indian series came out, including mine, a total of 600 patients. Diabetes invariably was one of the independent risk factors for bad thyroid eye disease and loss of vision. Dyslipidemia. Okay. Nowadays, it is also known that obesity has a low-grade inflammation going on. So that has a direct connection to thyroid eye disease. There's a mechanism where the excessive fat and excessive cholesterol in the body will give rise to a greater amount of reactive oxygen species and lead to inflammation and trigger the thyroid or vital inflammation. Vitamin D deficiency, smoking has long been known to be an independent risk factor, including acid smoking and iatrogenic hypothyroidism. You might think, oh, it's beautifully controlled. From hypothyroid, the patient has gone into hypothyroid. If hypothyroid is there, you're possibly going to get worse eye disease. So it's good to talk to the physician or the endocrinologist treating and make sure hypothyroid is never reached. So now we are thinking of what else to do. We've finished using steroid. We've finished using mycophenolate. So now we come to rituximab. Rituximab is a monoclonal antibody, which is one of the second line of treatment for thyroid eye disease. It's good for relapsing orbital inflammation. It starts working slowly, so it's not good for dysthyroid optic neuropathy. Not, when the patient first came to me. But it's going to deplete the B cells for 12 to 15 months. And so, because this was undertaken in collaboration with the endocrinologist and immunologist. He's a 76-year-old gentleman, remember. And we are still just about coming to the end of the pandemic. So, the immunologist said, okay, let's give him a flu vaccine and the meningococcal vaccine and then give rituximab. This is not really compulsory, but then, it was a call taken by his treating immunologist. And before giving the rituximab, there has to be a gap of 4 weeks. So he underwent 2 doses of 1 gram each. However, recent studies show that even a single 500 mg rituximab dose gives almost the same amount of efficacy for thyroid eye disease. So after 6 months now, you can see the eye disease is inactive. You can see that the orbit has been decompressed. This is where the bone was thinned out and including the medial wall. So the next step we are planning is correction of strabismus. 10% patients are going to finally meet a strabismus correction. Now, in this context, this guy got back his 6x6 vision. But let's look at this gentleman. Okay, this is a picture from when somebody else was treating the patient. Let's look at what all the risk factors are. The patient is male. He's a smoker. He has uncontrolled hyperthyroid. Okay. He has dysthyroid optic neuropathy. He has corneal breakdown. He underwent tarsorrhaphy, which opened up again. With all this amount of edema and proptosis, don't expect the tarsorrhaphy to hold. You have to give a nice dose of steroid, only then you can do a tarsorrhaphy which is going to hold. And the tear film is disturbed, the ocular movements are disturbed. So the cornea is at great risk. And this patient was advised 500 mg IPNP. This is not a patient for 500 mg IPNP. That was for moderate to severe disease. This guy has serious side-threatening disease. He needs a high dose. However, he did not respond to 500 mg. And that was when somebody asked me, what do you want to do? I was very clear, we need a decompression, both for the optic nerve, and by decompressing, I'll also be able to, do a tight tarsorrhaphy, protect the cornea. But the patient delayed the decompression and wanted to have rituximab, which he went. Let's remember now, going back to the previous case, rituximab was not indicated in this sort of a situation. So, after 2 weeks, this is how the patient comes to me. Okay? Cornea is thinned out 80%, everything is popping out, the eye cannot close at all, and to me it looked like unless I decompress the patient, the next surgery I'm going to be doing is evisceration, or maybe the patient will undergo auto-evisceration anyway. So this was a fairly scary surgery, and I'm very thankful to my then anesthesiologist who did not tell me that the patient also went to something like 200 by 140 blood pressure. And because I had warned him that either I operate this patient today or I'm going to do an evisceration, he managed to bring down the blood pressure and gave me this patient to operate. So you can make out that there is no way I can get to the caruncle here. There's no way I can get to the fornix here. the eye and the conjunctiva, everything is coming in. So this is one of the few places where I would do an external approach, thyroid decompression, where I open up from here and remove the bone from the outside. So take off the lateral wall, and then we get place to shift the eyeball to the lateral side, and then do the medial wall decompression. Another alternative is calling in an ENT surgeon at the same time to do the medial wall endometrium. So after decompression also, the pain and the swelling went on. The patient was in severe pain, and so and we need to combine the treatment with a cornea surgeon who says, look, this is fungal corneal ulcer. Okay, you can't keep on giving him steroids. Now I'm stuck. I have to give him steroids. So we talked about radiation, but radiation once again takes a couple of months to start action. We needed to talk to the family. This guy is still going on smoking. Even though we told him to stop smoking, apparently every time his friends came visiting, he'd start smoking. So then finally I called in his wife and his brother and said, look, either you get him to stop smoking or, finish up with his mission. And this is a young guy in his 40s. He's a businessman. Now he's confined to a wheelchair. He's got PLPR vision. So I started off with intraorbital steroid injection. I repeated the plastinophy, and finally, after 8 weeks, this is where he came in. He got back ambulatory vision, and the eye settled down after the radiation. The next step is later. He needs to get squint correction so that the eye comes back to its position. Then he needs to get a corneal transplant. So here does it fit your definition of a difficult case? So how much time do I have? 10 minutes. Fine. Thanks. Okay. So this is again a long story. 15-year-old girl who came to me in 2015. Since childhood, she said she had a swelling of the eye. Sometimes it increases, sometimes it decreases. But it's now really become too much. And this is what he has in the orbit. So this has a kind of patchy appearance, including external component as well as internal component. Now, this is another thing that we have learned more about in the last 10 years or so. When I started practice, we dumped all of these under the heading lymphangioma, and when we became a little more evolved, we used a term called arteriovenous malformation. Okay. But we need to really differentiate. And how do we evaluate? We check for pulsation. If there's pulsation, this is a high flow lesion. For Valsalva and increase in dependent position. If it is that, it is a venous lesion. Does it increase in upper respiratory tract infection? So then there is a lymphatic component. Remember, in the eyes, the lymphatics are in the surface, eyelid and conjunctiva. There's no lymphatic inside the orbit. So it has to be a malformation. Does it enhance with contrast? If it does not enhance with contrast, there's no active blood flow into the lesion. Are there flowoids? Flowoids means when you image, are there black areas? If it's a flowoid, that means it's a very high flow lesion. That is flowing very fast. And how close is it to the vital structures? So these are the things we need to look at. And this classification once again has come in fairly recently in the last 12 years or so. It modifies the International Society of Vascular Anomalies. So we can have vasoproliferative lesion and vascular malformation. And among vascular malformation, it can be capillary malformation, lymphatic malformation, venous malformation, or a combined one. So this patient, there was, if you go back to the image, parts of it is enhancing with contrast, parts of it is not enhancing with contrast. If it is not enhancing with contrast, that is a lymphatic malformation. It's a no-flow lesion. But parts of it is enhancing and slowly. So that is a slow flow, no flow lesion, which means it's venous. So it's a combination of venous and lymphatic. It's a veno-lymphatic malformation. Okay, and it is not distensible. That means there's no increase in Valsalva. There is no increase when he bends down. And we be talking about macrocystic and microcystic appearance. If you look here, you possibly think there are some cystic spaces inside here. This also has bearing on what treatment we are planning. So now, once again, looking at the traditional treatments, we've got systemic steroids or local steroid injection. Systemic steroids are used in lymphatic malformations. Local steroid is used in infantile hemangioma, which used to be called capillary hemangioma. Propranolol is again used only for infantile hemangioma. Surgery is what used to be done, 20 years ago, but you can see how diffuse it is. It is all over the muscles. There's no way we'll be able to get the whole of it out. We do some amount of debulking, there's going to be a lot of bleeding. We might even injure some of the vital structures. And if it was a high flow lesion, that means an arterial malformation or a fistula, arteriovenous fistula, then there would be the role of embolization by the interventional radiologist. Now, in 2014, local sclerotherapy was not very well developed. Okay, so what I did at that time, that was kind of standard then. I injected cyanacrylic glue. You inject some glue, that part hardens, and then you remove that little part. So you end up debulking, but it is a cleaner surgery than simple operating. So 2018, she visited me again. She's much, much better than before, but she doesn't like the residual area, residual lesion. So by then, we are into use of bleomycin, which is initially an anti-cancer drug, which was initially used to sclerose the pleural cavity in pleural effusion. And that is where people got the idea that it can be used to treat vascular lesions also. So if you're not certain where the lesion is, you can actually open it up, look at where it is, and then aspirate part of it without moving the needle. If you've aspirated some blood, if the needle is still there, you know the lesion, the needle is within the lesion. You're not blindly injecting into the orbital structures. So then you change the syringe and inject back about 1/10 of the volume, and the dose is 1 mg per body weight. And this is the bleomycin. It comes in a 15 mg, 15 IU vial. So after the second bleomycin injection, you can see this is definitely better than what she was. But 2020, she comes back, she says, no, I still don't like this. No, she's a 20-year-old. She doesn't like. Now you see this on the scan, the lesion is only that much left, and it's very superficial. So I don't even have to operate, I don't have to go deep. So the second bleomycin injection was given just transcaracular, just into that area. And then in 2020, the pandemic came in, and so she came back for a follow-up. But this is the photograph she sent me, where this lesion has subsided completely, and she's happy with that. I would expect, then she'll probably come back again. But let's see two other examples. Transcutaneous sclerotherapy, because this lady had the lesion deep into the orbit. But you can also see this is a child less than a year old who developed a swelling and which increased rapidly. If you see the scan, you can actually see a fluid volume level here. So that is what is called a macrocystic lesion, where the RBCs settle at the bottom of the lesion. So a macrocystic lesion is very amenable to aspiration and sclerotherapy. And if you can see the child, this is way out in front. You don't even need to operate, but you do need to put general anesthesia. And after 2 sittings of sclerotherapy, the swelling has improved considerably. And this one is only for a contrast because this is not a very difficult case. Why didn't I give propranolol? Well, if you see, this is a typical infantile hemangioma. There's a lot of difference from this child. This started off almost at 1 year of age. Infantile hemangioma will start by 3 months of age and increase its maximum by 5 or 6 months of age. And this will grow slowly. This chap started off suddenly. If you see this, this is hyperintense, which means it's very highly vascular, it's very cellular, and you can actually see these dark areas, these are called flow voids. A capillary hemangioma or an infantile hemangioma is actually a high flow lesion. And sometimes in capillary hemangioma, if you try to inject, you'll actually see an arterial pulsatile blood flow. It will pop up from the injection points. So this is a patient who is ideally suited for oral propranolol. And in 3 years, she is now off the propranolol. You can see the entire lesion has cleared up, including the orbital component, iris component. There's a little bit in the upper lip left. So this is how we would differentiate between the different types of vascular malformations. And with that, I think we'll stop here. Thank you very much for your patient listening.
Thank you very much, ma'am, for sharing with us your uniquely difficult cases and your beautiful insights and astute management of them.
And while I'm here, may I invite all of you to the Karnataka Ophthalmic Society annual conference in October in Bangalore. We look forward to seeing all of you there. Thanks. So, and these children are on regular follow-up both with myself and with the pediatrician. And so far, none of the children, at least I've seen, have had a problem with bradycardia. Thank you.
Thank you very much, Consul.
I'm just trying to make sense of this MRI film.
In that case, maybe you should try holding it right first.
Okay. So,
Without, I see that you're perplexed, so without further ado, I'd like to take this opportunity to present the vibrant and vivacious registrar of Oculoplasty Department in Sankara Eye Hospital Shivamogga, Dr. Usha M. Ma'am, would you please take the stage and unravel the complexities of orbital imaging? So next, okay. So here this is the X-ray source. So that is being, it emits, it transmits X-rays, it passes through the tissue of interest, and then what happens here? Some of the X-rays gets absorbed and some gets transmitted without any absorption. So what is this? Depending on the density of the tissues, so what is the entire process called is, okay. So as the X-rays pass through the body tissues, it gets weakened or it gets absorbed. So this weakening of the X-rays is termed as attenuation of X-rays, and that is measured in terms of Hounsfield units. So here we have a large set of Hounsfield units because you have a large set of tissues starting from hair to metal, and you have a lot of numbers here, Hounsfield units. So how do you assess this? Under standard normal pressure and normal pressure and the temperature, the water is considered to have a Hounsfield unit of 0. Anything less denser than water will have a negative value, and anything denser to water higher will have a positive value. So how does the image look in a CT scan? So everything is black and white, right? So the tissues which has a higher attenuating coefficient, that is higher where it can attenuate to the maximum, will appear black. Sorry, will appear white. So bone being denser will absorb most of the X-rays, and that appears bright.
But whereas the air allows the X-rays to pass through. So that appears black. And the rest of the tissues, depending on their attenuating capacity, will have different shades of gray. I hope it is understood. So here in orbit, what we are dealing is somewhere here, right from here, minus 100 to 300. So there you can see, you basically you concentrate in that particular Hounsfield units in orbit. So I already mentioned the fluid, the aqueous, vitreous, and will appear dark. But whereas the air and the paralysis sinuses and the fat will appear dark. And the bone, being much denser, will appear bright. And the rest of the soft tissues, depending on their attenuating capacity, will appear in different shades of gray. So normally, in a human platform, there are 56 shades of gray. But a human eye can differentiate only 6% of the changes in the grayscale, meaning only 70 different shades can be identified by a human eye. So how does, I will explain this further. So when you try to display the entire 2000, around from minus 1000 to plus 1000, that is 2000 Hounsfield units in this 256 shades of grey, how does the image appear? It appears like this. So here you are seeing a bone and the brain parenchyma, but you cannot differentiate the details of the brain. But however, you can identify a subtle fracture in the outer table of the bone. Same thing when you narrow the Hounsfield units. So when you narrow this to a particular range, a width that is somewhere from 0 to 80, and you're setting up a level at 40, how does the image appear? So it appears like this. So you appreciate the difference, right? You can read the contrast, the details of the brain tissue parenchyma can be well appreciated here. You see here EDH, and here you see parenchymal hemorrhage, and the ventricles can be seen. So what you're doing here, you're narrowing this. So this 80 Hounsfield units, you're trying to display